Good morning, everyone, and thanks for joining us on a Sunday morning. In case you missed yesterday, let me introduce myself. I'm Joseph Gigante. I'm an academic general pediatrician at Vanderbilt Children's Hospital in Nashville, Tennessee. I'm also a member of the Practical Pediatric CME Planning Group and director of this weekend's course. Thanks for joining us again. We're so glad you're here for another great lineup of sessions and phenomenal speakers. Before we begin, fewer housekeeping items than yesterday, but several that I need to go over with you. First, you're welcome to continue submitting questions related to these on-demand lectures. You can use the green Questions for Faculty polling link on the session card to access the online question submission sessions, Conference IO. Once you get there, be sure to click on the faculty member to whom your questions are to be addressed before entering your question. If you prefer to have fewer browser tabs open, you can also access the question submission system using a separate device like your phone or your tablet. On your device, open your web browser and navigate to aapcme3.cnf.io. Either way, you can access the system, click on the session for which you have a question to submit your questions. Click the Ask button in your question and then click to submit. If you see a question that another attendee has asked and you really like the question, you can upvote that question by clicking on the icon to the left of the question. All the seminar rooms will be open 5 minutes prior to the start of the session. So our faculty for this morning's Q&A are Drs. Jennifer Lightdale, Stephen Selbst, and Paul Stricker. Thanks to the three of you for being here. And before we get started with the questions, let's go ahead and introduce yourselves to the participants. Dr. Lightdale, you can start us off.
Sure. So I am Dr. Jennifer Lightdale. I am a pediatric gastroenterologist at the University of Massachusetts and the UMass Memorial Children's Medical Center. I was thrilled to talk about these topics. I really enjoy providing education to pediatricians. I feel that so much of what I do in GI really deserves to be demystified. So please ask me questions. Joe, do you want more details? I apologize. Perfect, great, thank you.
Dr. Selbst?
Good morning, I'm Steve Selbst. I'm a professor of pediatrics at Sidney Kimmel Medical College, Thomas Jefferson University in Philadelphia, and I'm a pediatric emergency medicine physician at Nemours Alfred DuPont Hospital for Children, Wilmington, Delaware, right outside of Philadelphia. And I'm also a pediatric residency director, so I love working with residents and students, and I love working with all of you. I'm sorry we can't all be together in Chicago, but happy to answer any questions that you have about the emergency medicine talks.
Good morning, everyone. I'm Paul Stricker. I'm a sports medicine pediatrician in San Diego, California. I work at Scripps Clinic. And so I really love this because I'm one of you guys. As a pediatrician, I know these are the things that a lot of times come into our office. So it's really exciting to share different sports medicine types of issues that you probably see quite frequently. And even though we can't do hands-on workshops this time, hopefully these cases will be interesting to you.
Great. All right, let's get started with the questions. Dr. Lightdale, first question is for you. Question is, what's the appropriate amount of time to have parents sit infants up after feedings to help, hopefully, I guess, prevent reflux?
Sure. So obviously this is the question that parents are really wanting. What they're really asking is, when is it okay for me to put my baby back down? And the answer is, it's a little bit going to be dependent on the baby. So guidelines talk about 10 minutes to hold the baby up 10 minutes. I will tell you, we know gastric emptying time for 4 to 6 ounces of the feed is probably more in the neighborhood of 30 to 40 minutes. And that is going to still leave about 30% of the feed there. So a baby who's feeding often is probably never quite having an empty stomach. And if they are really prone to refluxing, you might need to be holding them upright a lot. And you see people doing that. So, keeping the baby in the holder on their chest, the Bjorn, so to speak, on their chest just all the time. And maybe we're a society that expects to be able to put our babies down, but you're really helping them with gravity if you hold them up.
Very good. Dr. Stricker, question for you. Patients in my practice often don't have great insurance and can't afford physical therapy, PT. Can you give us some easy guidelines for home treatments for patellofemoral pain, since we do see it very often in the office?
Sure. I refer to patellofemoral pain as the abdominal pain of general pediatrics. We do see it all the time, and it's really, really common, and it can be really kind of invasive to a kid's sports as well as their everyday life. You know, when they start complaining that their knee hurts when they're going to a movie or on a long, car ride with their family or something, then that really is important. So what's important is that, yes, patellofemoral pain can easily be treated at home. If you have the benefit of seeing a physical therapist, certainly that's great to have that guided, structured kind of treatment. But in this case, let me just first review the three common causes that really affect patellofemoral pain are their inflexibility and how that compresses the kneecap, then their strength imbalance and how that affects the way the kneecap tracks back and forth, and then what their feet do, if they pronate and their arches drop or not. So, and then the growth spurt factors in hugely, but since we can't control that, then we have to just remind them that may lengthen their time frame of getting better. So the easy one is examples of over-the-counter orthotics. Certainly you can use brands like Superfeet, Spinco, even Dr. Scholl's, just as long as it has enough solidity to it that if you put it on the table and press on the arch part that it doesn't completely collapse. And then when we talk about the flexibility issue, certainly stretching, and we can have them use a towel and wrap it around their foot and lie down and raise their leg up to stretch their hamstrings, bring their foot up to their rear end to stretch their quads, or do lunge stretches to help stretch their quads. Otherwise, butterfly stretches for the inner thigh stretch and flexibility, and then of course different kinds of IT band stretches. I also really emphasize to these kids that it's not just doing stretches for a little bit, it's frequently. I have them do it after their exercise when they're all warmed up and can benefit from that. I try to have them do it before they go to bed, so they're not so tight when they wake up. And then also love to use the meat tenderizer concept, get out mom's rolling pin and roll those muscles out to kind of loosen them up before they stretch. And then lastly, strengthening. We emphasize the VMO muscle and the gluteal muscles. And so again, straight leg raises can certainly help the VMO. One leg, little mini squats where they go down about 4 or 5 inches on one leg. Backwards leg lifts for the glutes, and then wall sits where they squeeze their knees together with a towel that's rolled up in between them. So hopefully these are helpful ways to really do a home program without having to feel like you're losing out if they can't afford physical therapy.
Great, those are great suggestions, Dr. Stricker. Thank you. Dr. Self, so a person put in a question about community emergencies. In your section on acute trauma, you spoke about improvised tourniquets such as tying a bandage around an extremity. Stop the Bleeding actually advises against these, as they can allow for arterial perfusion and stop venous outflow, worsening bleeding. Just wanted to see if you can clarify whether these are generally advised or not. We can't hear you. You're on mute.
Sorry about that. That's a great question. Thank the participant for putting that in there. Actually motivated me to go back and Google "stop the bleed." And actually, if you watch the video, they do advise against improvised tourniquets like a belt or a rope. They didn't actually say why on their video. But I have seen many other references, including a wonderful reference in JAMA from 2017 that says you should use any device that you have to stop the bleeding. Ideally, if you have a commercially available device that's recommended by the Stop the Bleed program, it's a Velcro kind of device that really works very well. I don't happen to have that. I don't know how many people in the audience do carry that with them in their cars. So if you're in a situation where the patient has a severely bleeding extremity, it's very clear, everybody says, including the Stop the Bleed campaign, everybody says to apply direct pressure to that wound. That's the most important thing. To apply pressure with any kind of gauze or shirt or whatever you have available to stop the bleed. But if that doesn't work, a tourniquet is indicated. And I can assure you at the Boston bombing, of the Boston Marathon bombing, where it was clearly shown that lives were saved by applying tourniquets to extremities, those people on the streets of Boston did not have the commercially available tourniquets that are recommended by the Stop the Bleed campaign. So use whatever you have available. It is recommended, actually, I didn't mention this in my talk, but if you want to get fancy, throw a stick in the middle of your knot, and then you can turn that stick around to make the tourniquet tighter and tighter. The key is to stop the bleeding. That's going to save the life, and I wouldn't be worried about the arterial versus venous blood flow in that situation. And if you're in a city situation, chances are that tourniquet's not going to stay on that long anyway. EMS is going to arrive, you're going to get the patient to a hospital, and you're not going to cause severe damage to that extremity. And even if you do, again, the goal is to save the life of the patient by stopping the bleeding. So I would argue, use the commercially available device if you have it, recommended by Stop the Bleed. If you don't have that, apply pressure and use any kind of tourniquet that you have available, including a t-shirt or a belt.
Great, thank you. Yeah, and I think you're right. That take-home point, Dr. Stubbs, is your primary goal is save the life, right? So, I mean, and again, I think your point of if you're in a urban situation, EMS is not too far away. You know, obviously different if you're in a rural situation, but you know, again, kind of saving the life is the primary outcome that you would like to accomplish.
And don't take the tourniquet off to check. I think that was an old recommendation. We used to say, oh, take the tourniquet down, let's make sure there's blood flow. The latest recommendations are to, once you put it on, leave that tourniquet on until you get to definitive care. You don't want to start rebleeding again while you're checking on things. Again, if you're out in a rural area and it's going to be a few hours, that's a different story. But in the city, don't take it off to check.
Yeah. Dr. Lightdale, I've had GI prescribed vitamin E for fatty liver. Any experience or thoughts about that?
Yeah, I thought that was a great question, and I'll answer it. But before I do, I just want to tell you, Steve, I was on call during the Boston Marathon bombing, and I will tell you it was, I'm listening to you, and I'm thinking you just never know when something like this may be on the line. So thanks for motivating the gastroenterologist. Okay, getting to vitamin E and fatty liver disease. So I think it's an important question because everybody wants a medication. Everybody wants a therapeutic to take when they're sort of being told that the child has fatty liver. But unfortunately, while vitamin E looks promising, really no systemic reviews at this point show that it actually does anything, particularly if there isn't steatohepatitis. So the studies that have been done on vitamin E have been in adults who are non-diabetic, obese adults with biopsy-proven NASH, the non-alcoholic steatohepatitis. And the vitamin E can decrease the liver enzymes, but also can have a change, can seem to help at least with change on biopsy findings, less cirrhosis developing, so less fibrosis. But in terms of, you know, your 14-year-old obese child who I'm, you know, the AAP, and I would agree you should be telling them, okay, you're overweight and we're going to worry about your health and I should do some looking. And again, the liver guidance is for you to check liver enzymes. And then if there are elevation of the liver enzymes, what I would like to empower you all to do is to go forward and start talking about non-alcoholic fatty liver disease. That doesn't necessarily mean there's the hepatitis yet. And what you want to do with NAFLD is lose weight. So unfortunately, vitamin E does not help that. And really, if you focus on vitamin E, you're missing that opportunity to really impress on those kids how important it is that they change their lifestyle, and to the family, of course. The other thing I'll say is, like all vitamins, they're over the counter, seems benign, but like all vitamins, they can be side effects. So you have to worry about GI side effects, headache, and then actually there's even concerns with excessive use of vitamin E, actually to the discussion around bleeding, to hemorrhagic stroke. So certainly you want to be a little careful and everybody should be, I think my colleagues should be doing this as well, very careful promising anything with vitamin E and always counseling that it's really not the antidote we know that at the moment. So to use it cautiously.
Great, thank you. It seems like we want to, kind of be natural using vitamins, but I think your point is well taken. I mean, there are side effects and toxicities from hypervitaminosis for a number of these different vitamins. So as I said, I think, in many instances, kind of patients and probably more, families and parents want to do, as I said, kind of treating a condition naturally with vitamins, but they may not, first of all, they may not work. And secondly, there may be some bad side effects that even natural treatments can lead to. So thank you. Dr. Stricker, you kind of addressed this in the previous question, and so I'll ask you this question, maybe go on to the next one. As far as kind of resources for patellofemoral syndrome, there's kind of a similar question about websites and resources for not only patellofemoral dysfunction, but other sports injuries. Do you want to comment on that, or are there any other resources that you want to add in addition to what you just spoke about with patellofemoral syndrome?
Sure. Yeah. We oftentimes, if you have a local sports physical therapist or a local school trainer, that you can talk to, a lot of times they will be more than happy to provide you with instructional worksheets and things, or some pictures that you can give to your patients, because they understand that in some areas kids can't afford it, or parents don't have that kind of insurance. And so if you get good friends with some of them, or if you've used a physical therapy place before for other patients and you've already sent them business, it's totally fair game to ask them to provide some things that you could hand out in your office, reassuring them, of course, that if you do have a patient that has insurance, that you'll be using them again. But I think that that's a great way to get some good use of your local people. Another thing is the online resources now, of course, are getting quite huge with YouTube videos abounding. But also just remember that there are some more reputable places than others. Of course, standard names like Mayo Clinic, you can always research. They have good physical therapy exercise resources on their website. Health.harvard.edu is another one. Healthline.com is a place that you can search and find some physical therapy exercises. ChoosePT.com. So ChoosePT.com is another place that can have them, and you search by body part usually. So sometimes they're not specific, like swimmer's shoulder or something, but if you search by body part, at least it can get you started. Again, some therapy is better than none. And of course, WebMD.com. Again, sometimes you have to search enough and search a little bit harder to find some of these, but at least these are a few of the websites that can get you started if, again, there's not somebody locally that you can develop a great relationship with. So hope that helps.
Excellent. Thank you for those excellent resources, Dr. Stricker. Dr. Selp, so one of your pre-recorded talks is, great title is There a Doctor in the House? And, what do we as pediatricians, what can we do to help maybe people out in the field where we're out in public and dealing with potential emergencies or medical situations that are just kind of unexpected? So it's interesting, and one of the things that you talk about is, and this is something that I think many of us have actually probably experienced, where you're on a plane, you're a physician on a plane, and there's the call overhead, is there a doctor on the plane? Which I think everyone's heart rate jumped, everyone gets a little tachycardic at that point, and then there's that question of issue, do I wait to see if there's someone else on the plane and they raise their hand, or do I raise my hand? So as I said, I think that it's a situation that's actually not uncommon. And one of the things that you talk about in your talk, and I think one of the reasons why, in addition to just that anxiety of potentially having to provide care for an adult, is that issue of, if I provide care, am I putting myself at risk for a lawsuit and malpractice? And I think especially in the litigious society that we live in today, I think it's a very real concern. And you talk about the Good Samaritan law, where we really, physicians, if they are providing medical care in good faith, are actually protected against potentially, as you kind of think, you talk about, you can get sued, but as far as the suit actually going through and sticking, it's going to be minimal. So, and one of the issues related to that is that if you are in the Good Samaritan laws, that you can't accept any kind of payment for the services you deliver. So this is interesting. This is actually, I work closely with the house staff as well. And it was about a year or two ago where I had a resident who was on vacation and flying to England. And on the flight, there's the is there a doctor in the house? So she reluctantly got up, and it ended up being a toddler who had a febrile seizure, who she took care of the child, and basically just watched the child. The seizure ended. They gave some antipyretics. The plane landed, child was fine, and the flight crew was just overjoyed. And to thank her for her care for that febrile neonate or febrile infant with the seizure, they gave her a free airline ticket and $50,000 frequent flyer miles, 50,000 frequent flyer miles. So the question is that, obviously if someone, pays you for that service, that's one thing, but how does that kind of thank you fall into that category of, whether or not you're paid or not paid, and does the Good Samaritan law still hold in that specific situation?
All right, good question. It does come up. I am not a lawyer, so that's my first disclaimer. But I would say, and it is actually not the Good Samaritan law, is a law very similar to the Good Samaritan law that applies on airlines. And I would say you should forget all that and just do the right thing. There is a very small chance you could be sued. Like you were saying, you can get sued for anything in the United States. But if you acted in good faith, the judge is going to throw it out. There's never been a successful case against a physician who acted in good faith, unless you do something very, very grossly negligent that every doctor in America would say, I would have never done such a stupid thing like that. They're not going to win their lawsuit when you're acting in good faith. So I would say the most important thing is to step up and do the right thing. Don't worry about the laws, because the law is different. In some countries, you're obligated to get out of your seat and do something, like Germany and France. So what happens if you're on a French airline, but you're flying over the United States? Whose law applies in that situation? What happens if it's a German patient and you're flying in the United States? Don't worry about the law. Just do the right thing. Everybody does get a little heartburn when you hear that call. And I think that's because you know that 90% of the time it's going to be an adult. It's only 10% the rare situation where your house officer got to take care of a child. Almost always it's an adult patient. And I think it's also very scary because, when you're home and when you're in your own hospital, somebody's going to come to help you. When you're on that plane, it's just you for the next hour and a half or 2 hours till that flight ends. Nobody's coming to transport that patient out of your office. So it is a little bit scary. But I would say do the best you can. And I would also say never forget that you're not alone. There's a ground crew that you can talk to. You can ask the flight crew, I want to speak to someone on the ground. You won't directly speak to them, as I said in my talk, but you'll be able to contact a ground crew that is very experienced in emergency medicine, and they will guide you through this. In terms of the payment, it is certainly true. If the airline offers you a free drink or move up to first class for the rest of the flight, you should take that and enjoy that as your reward. My experience, they never do that. They give you a thank you, and that's the end of it. But if they offer you a free drink in first class, take it. If they offer you 50,000 miles and a free flight, it's a little bit more controversial, but I would still say the patient is not paying you. The airline is rewarding you. You're not getting payment from the patient. So it's probably okay to accept a reward like that as well.
And it's interesting, I think, when you hear these stories as well, when they make it to the media, how oftentimes there are other healthcare professionals on the flight. And I don't know if you saw this. This is maybe about a month or so ago, where there's a mom who went into, preterm labor and delivered, and there were like 3 NICU nurses who were on the flight, which was like, how lucky was that woman? So,
yeah, there is usually someone on the flight who can help you. An experienced adult physician who takes care of adults, or a nurse. It's great to have a nurse. They're usually much more calm than I am when it comes to a scene like that. It is scary when you're on the scene. When you're in your own office or the emergency department, you're going to have helpers, where the equipment is, how to reach a consultant for help. It's a little bit different when you're on the scene at a street emergency or on an airline, but we have to stay calm and do the best we can, and usually it works out well for the patient.
Yeah.
And I have to give a true confession here, a funny story. I was on a plane with a team traveling from somewhere to somewhere, and got that, is there a doctor on the plane call? And so the team trainer was also starting to come up and get me, because he saw this woman get up out of her seat, and then she passed out and went down. And later on we found out, of course, she was just hypotensive and everything was fine. But so I get back there, and of course, literally as I get back to look at her and start to observe and see what's going on, we hit the worst turbulence I've ever been involved in. So me, very non-motion good. I'm very bad with motion sickness. And so I start getting so nauseated that I literally have to lie down on the floor of the plane myself. And so they had to make another overhead call for a doctor to take care of the woman until I was so pale that I could hardly stand up. So anyway, sometimes it doesn't matter. Someone else will have to come to the rescue, but I just had to throw that out there.
So I think the general rule with any, whenever you respond to emergency is take care of yourself first. You have to make sure you're safe. In an airplane, there's not much that can happen to you other than turbulence. Yeah. If you respond to an emergency on the street, on a highway, you really want to make sure you're pulling over at a safe distance. And if you can't find a safe place to pull over, no one would hold that against you. You have to take care of yourself and your family first before you respond to an emergency. So yeah, you take your seatbelt off in a plane. There's a little bit of risk there, but higher risk when you're on the highway.
Paul, I'm glad you're able to make it. Dr. Lightdale, what is the recommended duration of PPI or H2 blocker treatment? Would it be dependent on symptom relief or manufacturer recommendation?
So the infant guidelines that I'm really tackling in the GERD talk about a 2 to 4 week empiric trial. So the concept there is, did you see improvement or you didn't see improvement? If you did see improvement, you had done the right thing, which is you calculated a weight-based dose. And in infants, it's basically, well, actually, you really have to look at the drug. So I think there's been a real change from ranitidine to cimetidine or famotidine because ranitidine was taken off the market, which is a whole other talk I can do. But in any case, so you really should look at and calculate a weight-based dose, milligrams per kilo. And then what infants do very well is they grow. So over those 2 to 4 weeks, they literally are weaning themselves. The dose is literally becoming less for their weight. And sometimes what happens at the end of 4 weeks or 6 weeks is they're symptomatic again, and you realize, oh, now they're getting a subtherapeutic dose and you need to adjust the dose up. Often, in a sense, they wean themselves off. And Joe, I'm going to skip ahead, but somebody asked a question about PPI, how to wean them off. The answer is just let them outgrow the dose. I mean, for PPI, which is basically 1 to 2 milligrams per kilo per day, is your therapeutic dose. When you are below 0.5 milligrams per kilo per dose, usually, so, you know, under a milligram per kilo per day, you are subtherapeutic. You're really, it's at that point homeopathic, and you can just stop it. So, you know, so just infants do you the nice favor of growing, and they will wean the drug for you.
Excellent. Dr. Stricker, as a specialist, you do a lot of, kind of quotes, prehab recommendations every day. As a primary care provider, general pediatrician, if I see a child once a year for a physical or sports physical, do you have any suggestions for recommending appropriate prevention exercise to help prevent overuse injuries?
You're muted, Paul.
We can't hear you.
Yeah, sorry about that. Yeah, great question. So if you're having that one time a year physical or you visit where you don't have a lot of time, certainly, you know, there's a few questions that are always super helpful. You just kind of want to find out, you know, what is their current activity level? Because a lot of kids will be training all summer, but some of them are totally sedentary, and then there's sports coming up in a couple weeks. And so, right, I always ask them then how much time until your, you know, training season begins. So, then I also say, I like to find out, are they on one team or multiple teams, or are they in multiple sports? Because again, you want to find out, are they in, you know, 3 sports that are going to over their shoulder, like they do water polo and then volleyball and then, you know, baseball pitcher or something like that? Or are they in sports that are very complementary and use all sorts of their different body parts? I like to find out, you know, are they already doing a resistance training program? And find out what that is, because a lot of kids will say, oh, well, I'm already doing strengthening. Well, okay, what is that? Well, it's bench press, biceps, and, you know, squats. But it's very non-sport specific for the things that they need for their particular problems. So when we think overall, if you've got a basketball player, your first initial thing is just, okay, ankle rehabilitation, ankle prehab to try to protect them. So ankle sprains are super common in basketball and volleyball. And so those kids, I usually ask, have you had ankle sprains before? And if not, here, let's address this. You know, either I can give you this handout with these exercises to do, recommend a physical therapist, that kind of thing. So it doesn't have to take a lot of time. It's just being aware of their particular situation. You know, are they coming in completely out of shape and tight, or are they already doing a good job? ACL prevention programs now, of course, are pretty much everywhere, which is so great. Anything you can do to reduce that, especially in soccer and basketball. So those would be helpful to remember if they're in those sports. And then, as usual, any kind of overhead athlete, swimmer, any kind of throwing athlete whatsoever, a really good rotator cuff and scapular stabilizing program is key. So we already talked about certain resources for actual exercises, but in general, if you're thinking those clusters of sports, those kinds of rehab injuries to help prevent, and then just asking a few general questions that really wouldn't take more than just an extra couple minutes in your routine visit. So hope that gives you an edge.
Can I just involve Paul here for a minute? In my talk on missed cases in the emergency department, we had a patient, or I'm aware of a patient, it wasn't my emergency department, where Patelloferal syndrome or pain was diagnosed, and unfortunately no one examined the patient's hips to recognize that the child had SCFE, subcapital-femoral epiphysis. So I'm sure you would agree, before we make a diagnosis of a knee problem, examine the other joints. For some reason, subcapital-femoral epiphysis, those kids have referred pain to the distal thigh and the knee. I'm not sure, maybe you understand why that is, but we've seen that many times. The patient comes in complaining about his knee or his distal thigh, when in fact he has a hip problem. So really very important for people to examine the hip in an adolescent patient.
Yeah, 100% agree. And again, I'm just used to it. When the knee comes in, I always examine the hip and the ankle and the foot, just to kind of make sure. But it's also, kids that are runners and cross country, that kind of thing, where there's a high risk of femoral neck stress fractures. Same thing. They come in with thigh pain, and it's usually like mid or distal thigh pain. And so people are always sending them to us for their potential knee or a quad strain, and they haven't even done a hip exam. So yeah, great point. Of course, that's internship 101. I think we really need to always remember that.
Yeah, I was going to follow up that point. And it's a great point, Dr. Selbston Stricker, is that whole issue of, as you said, Paul, just intern 101, actually even medical students, like, patient comes in with knee pain, examine the joint above, the joint below, right? Examine the ankle, and especially kind of examine the hip. And those are, and that, Dr. Selbst's a great point of just missed cases, is the patient who comes in with the chief complaint of knee pain, kids just don't really kind of localize pain very well. And, you examine the knee and the knee is fine, that's great, but they've got, a septic hip, or they've got subcapital-femoral epiphysis, and so you've missed it completely just because you didn't examine the joints. I think that's a great teaching point I always make with trainees, but I think also kind of a great reminder for all of us who are in practice, because I think especially in our busy daily lives, again, do a quick knee exam, it's good, take some ibuprofen and let me know if it gets worse, and you can be at risk for missing some real significant pathology.
Actually, with every injury, I always teach my residents and students to leave that injury alone. No one's going to miss that obvious injury. In my talk, I have a severe dog bite to the face. No one's going to miss that. But leave that alone. Go to the rest of the patient and examine the rest of the patient. A kid fell off a sliding board. He has an obvious deformity of his arm. That may not be his only injury. Forget the obvious deformity. Examine his head. Maybe there's a head injury as well. Maybe he has a back injury. Maybe he injured his kidney when he fell off that sliding board. So I think it's a good point to tell the parents that this is what I'm doing. Otherwise, the parents think you're crazy. Doctor, I told you it's his left arm. Why are you examining his right arm? So I warn the parents in advance. I see the injury, but let me examine the rest of little Johnny first to make sure there isn't a secondary injury that may have been overlooked. Like, we do see kids with back injuries when they fall off a sliding board, and it could have injured their kidneys. And so we want to examine the rest of the patient first.
Yeah, so as kind of a follow-up to that, Dr. Subs, actually great, didn't plan it, but a great segue for kind of, one of the talks that one of your pre-recorded talks is for missed cases. So I think, are there any highlights or anything kind of that you have seen, I guess in your own personal experience and kind of what the literature suggests as far as what are some of the, maybe top kind of 1 or 2 diagnoses as far as what a primary care provider or general pediatrician might see in their office and kind of a diagnosis of a more serious or significant disease that they may miss?
Yeah, I think there's a few that I had in there. I put in some classic examples that taught me a lesson. And one is vomiting is not always a GI problem. We see kids coming in with vomiting. I'm sure Jennifer would agree with this. They come in with vomiting, the first thought is, oh, it's a GI problem. It must be a GI bug. And if they have vomiting and diarrhea, well, it usually is a GI bug. But if they don't have diarrhea, you clearly have to broaden your differential diagnosis. And the case that I presented was a child who had a brain tumor. So we do have to think about the central nervous system, and I think that often gets overlooked. In that case, nobody even documented in their note that they did a neurologic examination. They weren't even thinking about increased intracranial pressure as a cause of vomiting. But I've also seen a patient go home with diabetic ketoacidosis, vomiting and vomiting and vomiting. He was given some ondansetron and sent home and thought to be a GI bug, and no one checked his urine or his blood sugar to see that the patient had diabetes. So I think the key is if there is vomiting, it's usually a GI problem, but you have to consider other conditions as well as a cause of vomiting. Don't always refer to the GI doctors.
That's a great plug for my vomiting talk. So thank you.
It brings up another great point, though. When you're talking about kind of missed cases and things that happen in my office, I really want to empower all of you attendees and encourage you that, first of all, you are the one examining the patient and not I'm talking about x-rays in this case, not the radiologist. And the child is not always great about localizing their pain. And so, the classic kid comes up and there's an arrow where the radiologist put where supposedly the pain is. And then when you examine them, that's not really where the pain is. And the radiologist, who didn't have the luxury of examining them, looked at that spot, just like Steve said, just kind of go for the main thing, but they didn't look elsewhere and miss like a stress fracture or a bone abnormality or something else. But it happens a lot where I see a lot of our pediatricians just trusting the X-ray report. And I'm like, but remember, you're the one who had the great gift of examining that patient. So please, take a couple seconds, make sure that where that patient hurts, if you get an X-ray, look at it yourself, even though we're not radiologists, but that way, and if not, just take it down with them and show them, say, hey, can you please explain this? Because I think this might be weird, or this is where the kid hurts. So take advantage of that. A lot of things get missed and show up in our clinic because of that.
I think another area of referred pain is with testicular torsion. Those children, those boys come in with abdominal pain very often. I'm still not 100% sure why that is. I think it's some boys just don't want to talk about their genitalia, don't want to tell you that. They want you to find it on your own. But I think there is clearly some referred pain to the abdomen. So the cardinal rule is any boy who comes in with abdominal pain, you must examine the genitalia at some point to look for testicular torsion.
Yeah, Steve, I think that's I think boys just don't look down there.
Right.
So it may be testicular pain, but they're right. Exactly. They're telling you it's in the belly, and again, it's up to you to figure out. And again, that's another, intern 101, but another great teaching point. And again, a good reminder of any male with abdominal pain, do a good GU exam. Be sure there's no GU pathology that's either contributing to the pain or the patient not being upfront with you as far as exactly where the pain is.
And similarly, if there's minor trauma to that area, and there always is minor trauma to that area, boys in the audience would know that. If there is minor trauma, that doesn't rule out testicular torsion. So you have to carefully examine the patient, consider that if there is swelling or significant pain on one side of the scrotum, you still have to be worried about testicular torsion in that situation as well.
Yeah, and again, and kind of going back to that, your point about vomiting, it's just, in order to have gastroenteritis, you got to get, vomiting, you got the gastro part, but if there's no diarrhea, there's no enteritis. So don't give me a diagnosis of gastroenteritis. So I will push back on medical students and house staff. It's like, you can't make that diagnosis. There's no enteritis there. So, and then, so depending on the situation, one of the things I'll also sometimes push back on, it's like, all right, prove to me, just as exactly what you said, that case you described, prove to me this child's not vomiting because of a brain tumor.
Right.
And then you get, tell me about the neurological exam. Well, we didn't do one. It's like, okay, go back to the room,
Go back.
do the neurological exam, then come back to me, and again, prove to me that this patient doesn't have a brain tumor. So again, it gets back, your point is so well taken. The vomiting is obvious. So do the rest of the exam and, be thorough to be sure there isn't any other process or any other condition going on that might explain the findings.
Right.
And guys, if I can mention with torsion, ovarian torsion will lead to intractable vomiting. I actually don't think I talked about that one in my talk, but the teenage girl who keeps coming back, you better make sure you're not dealing with ovarian torsion.
Yeah. That's often missed. That's correct. That's one that's often missed.
All right, Dr. Lightdale. Often see premature infants discharge home on a PPI. When is it appropriate time to discontinue? I don't know if this is, you kind of answered this already, but when is the appropriate time to discontinue? Haven't had any obvious spitting up and they're gaining weight well. So would this fall into the category of let them outgrow their dose?
Good, you learned something. Yes, that's great.
Yeah, I'm paying attention. All right, let's go on to the next one. Is obesity the main risk factor for non-alcoholic fatty liver disease? Should we be worried in those children with normal BMIs but poor nutrition and lifestyle?
So the answer is absolutely, obesity is the main risk factor for non-alcoholic fatty liver disease, with alcohol being the main risk factor if you're an alcoholic. So, technically in adults, it used to be alcoholic fatty liver disease, and then they sort of realized, oh wait, obesity is an even bigger discussion. There are genetics to this, and we do have people who look thin but have metabolic syndrome. If you're dealing with a child who comes from a family with metabolic syndrome and they are normal BMI, but you're already worrying about type 2 diabetes, chances are, sure, you're going to be thinking about you're going to be thinking about the liver. That's rare. I will tell you what we see a little bit of are the very thin, unfortunately, anorexic, so eating disorders also can have fatty liver disease. And so it's really interesting, like clearly both obesity, but also malnutrition can put you at risk for fatty liver disease. So the answer is lifestyle is important to your liver. Your liver is what is really bearing the brunt of what your lifestyle is. And also will bear the brunt if you are, if you're starving. So something to be knowing about, but I'll leave it there.
Dr. Stricker, if a young athlete has an overuse injury, then does physical therapy add more overload and potentially make the injury worse? Do I need to have the child totally rest for a few weeks before beginning physical therapy?
This is such a good question that I actually took some notes down just so I wouldn't forget important points. But first of all, thank you for asking this. In most cases, if you want to give the kid a few weeks of rest, they're not going to do it. I get a lot of kids because they say, well, my doctor said to rest for 6 weeks, but I'm not going to do that. So first of all, that's usually not going to work anywhere. But second of all, we have to remember when kids truly stop everything, if they actually listen and say, okay, I'm not going to do anything for 3 or 4 weeks, what happens is that we see that those kids during that time lose flexibility, they start to lose a little bit of strength, but they start to feel a little bit better because they're not doing anything. And so 4 weeks goes by, they go back to their activity. Now they're tighter and weaker, and their pain comes back not usually more quickly, but usually more profoundly. And so unfortunately, total rest, it can often backfire on you. So we really very rarely have to do that unless it's a major traumatic injury. So this brings me, of course, to the concept of relative rest, which is what we kind of live by in sports medicine. It's when a child can either still work on body parts of their sport that are safe. So like if you have a basketball player with an ankle sprain, they can get out there and shoot free throws until they're blue in the face. And I always remind them how many games are won at the last second with a free throw. But it allows them to still be involved in their sport, still feel like they're connected, but they're not injuring the part that really truly needs to be resting. The other thing that we have to make sure is that they can still and need to maintain strength and flexibility of their non-injured body parts. I've had a lot of kids that have a shoulder injury and they can't go throw or they can't do volleyball but all of a sudden they're sitting around doing nothing because they're like, oh, I can't play my sport. Well, and if they're in their growth spurt, then they've just gotten tighter and their legs are now going to be subject to knee pain when they go back. So we'll often have them maintain, activities with their non-injured body parts. And I truly have found over the years that this profoundly helps keep their mental attitude much more positive while they're waiting to get back to their sport, because if you give them the mandate that they can't play their sport and that they can do nothing for 3 or 4 weeks to just sit out and rest, that really plays with their minds. This way we can kind of keep them involved, and that really helps them also accept their treatment a little bit more easily, because they know they're still doing something to be involved with their sport, be around their teammates, still learn from their coach, that kind of thing. And then lastly, we'll have the physical therapist or the home exercises address the supporting areas first before we dive right into the part that's been injured, so that we can gradually address the injured areas. So if you've got a volleyball player or a throwing athlete or a swimmer that has a lot of shoulder pain, then we'll spend a lot of time working on their legs and their core and their scapular exercises before we ever really start to go in and address the rotator cuff itself. So I think that like I said, I wanted to put these points down because I feel that they were so important. This was such a great question. So total rest, there's very few cases where that really helps. Otherwise, there's lots of steps you can do in the meantime to not only keep the kid involved, help the rest of their body, and then address the part that's injured. So hope that helps.
Dr. Phelps, there's a question that just came in. Actually, I had one of these about 6 months ago. Any tricks for removing multiple tiny splinters on the hands, greater than 60, failing to complete removal after 2 ED visits?
We're going to talk about procedures later on today. If you have multiple ones like that, you may even need to sedate the patient, although if they're very superficial, I wouldn't be too worried about them. But I usually use an 18-gauge needle and just scrape the top layer of the skin. It's really painless if you scrape very gently and you're not puncturing the area. But with the multiple splinters, that's going to take you a while, so be prepared to sit there for a while. And if you have an uncooperative patient or a very young patient who may need sedation for this, you're going to have to refer that patient to a hospital.
Very good. Dr. Lightdale, is oat cereal or other cereal preferred as a thickener now due to arsenic and rice?
Right. So there are no guidelines yet about this, but I think there was even a recall last week around rice cereal, where one of the major companies, I believe, has decided not to make it anymore. Anyway, in any case, it is, there's been a secular trend towards oatmeal. And the answer is, yeah, I see a lot of people using oatmeal to thicken their formula or the.
Are you a big proponent of thickening formula? Is that common advice or common recommendations that you make to patients when they come to you?
So the mistake I see is that people, and the guidelines frankly set you up for this, but the mistake I see is that people will try thickening before they really go through the process of deciding if the baby actually is atopic and showing you the milk protein allergy. Milk protein allergy, of course, is a misnomer. It's really an intact protein sensitivity allergy, the immune system reacting to intact large molecules of protein. And if you stick a grain into a formula, all you've done is give them another big molecule of protein to now react to. And so often those babies get a lot worse, and they may not be spitting up as much, but they're very uncomfortable. They actually become constipated, and you've just made a miserable baby out of thickening the formula. So words of advice are: sort out if you're dealing with milk protein allergy first, really looking at the baby, looking for stigmata, taking a family history, and deciding if you need to take a hypoallergenic approach to the baby's diet that is going to be far more effective for that baby than thickening with oatmeal or rice or anything else.
Very good. Dr. Stricker, can you go over OCD versus patellar tendonitis and really going over kind of key physical exam findings?
Yeah, I think when you think about OCD of the knee versus patellar tendonitis, there's probably maybe three things right come to the top of my head that would be very differentiating factors. So for instance, an OCD lesion in the knee is going to typically have non-focal pain. They're going to have these vague complaints of chronic intermittent pain and swelling. And very often you can't find a point tenderness. The second thing is the recurrent true effusion in the knee. These kids will really have recurrent swelling. And the fact that the pain with activity is usually more generic. It just hurts if I'm doing running and jumping exercises. They can't really, it's not really usually anything too specific, versus patellar tendonitis, which is very focal pain right at the distal pole of the patella. There's no effusion in the knee whatsoever, and there shouldn't be. And their pain is usually pretty specific. If I'm going downstairs or running downhill or landing from a jump, those are usually, they can be pretty clear about it. So I think when you look at those two pathologies, fortunately, there's about three things that I think right off the top of my head would distinguish those very, very easily.
Great, thank you. Dr. Phelps, one of your pre-recorded talks was on psych emergencies, and I don't know, this is probably maybe ask you more kind of commentary more than kind of a question, but I think it's something that I think we're seeing around the country, and I think probably, our institution is similar to yours, where we're seeing so many more children being diagnosed with psychiatric conditions, being placed on psychiatric medicines, and I think unfortunately kind of going to the ED and that the whole issue of just kind of what kind of actually the lack of resources. And, again, it's not uncommon for a child who comes in with suicidal ideation to be in our ED for several days before some kind of inpatient psych facility space opens up. So as I said, I don't know that that's really kind of a question, but as I said, I think it's clearly something that I think that's being seen around the country. And I think, general pediatricians and primary care providers are seeing so many more, of these children coming in with these diagnoses on these meds. And I think sometimes getting to the point where they do need to go to the ED because of, again, usually it's suicidal, homicidal ideation. So as I said, not really a question, but just kind of wondering, kind of get your thoughts on that and kind of how you've seen kind of the world kind of change, or kind of your patient experience change over the course of the years that you've been doing emergency medicine.
It has definitely changed, and it's definitely a terrible problem. I used to brag to my colleagues across the country that our patients, we almost always are able to find a placement for them in an inpatient facility. For the last couple of years, though, that's not true. The mental health facilities in Delaware and Philadelphia area are overwhelmed with patients. And most of the children now, we know they're going to stay in the emergency department for 1 to 3 days or 4 days. It's really a terrible situation. There is no facility for them. Where my hospital is now talking about building a inpatient psychiatric facility. We've never had that. And most hospitals across the country don't have it. Most children's hospitals don't have a psych facility. But the situation is so bad that we are talking about having a small facility. I'm sure that will be overcrowded very quickly, and we'll still have patients sitting in the emergency department. So the ED is the place of last resort. I think if anyone is uncomfortable, certainly if the patient seems severely depressed or threatening suicide, it is definitely appropriate to send them to the emergency department. It's not a great place to see children. It's a very scary place for everybody, but especially somebody who's already agitated and has a psychiatric illness. It's not a good place for them to be. But we very quickly get them into a quiet room with no stimulation, with nothing around them that they can hurt themselves with, and we watch them very carefully. And we're lucky that at least our psychiatrists are going to get to evaluate them. Our social workers are going to help to try to get placement. But I think we're all frustrated. It's going to be a long drawn-out course because there isn't a good place to send most of these kids. I think we still play a role. I said the emergency physicians, pediatricians, our role is to do the screening. We have to screen patients. I'm sure the pediatricians in the audience are very good at this. I'm sure they recognize with the pandemic how common this is. We've seen so many patients, almost all the patients who come to the ED now, almost all the adolescents have some mild to moderate depression. And it's just because they've been out of school, they've been away from their friends, they've lost family members, there's economic hardships. So we see a tremendous increase in mental illness in our patients and in the country. So it really is important to screen these patients, because if you miss a patient, most of the kids who have committed suicide have been to a provider in a month or a few months before they committed suicide. And so if we can at least screen those patients for depression, we might be able to avoid some of the suicidal deaths. So it really is a terrible problem, and I think we all need to work together to get better resources in this country and to do screening and, if necessary, get them to the emergency department if there's a significant risk.
And I just throw a little word on there too, because it's obviously not usually that severe, but in sports medicine now we're seeing a lot of mental illness and need for addressing mental health because of course there's so much pressure in kids' sports. It's ridiculous, but at the same time, it used to be, taboo because people would say, oh, they think it's just in my head or whatever. And we didn't have any idea, oh, this guy's a superstar athlete or this girl's a superstar athlete, how could they possibly be depressed? But when they have an injury that ends their season or potentially ends their career as a future collegiate or potentially pro athlete, it's a mentally devastating problem. And I'm very, very tight with our local sports psychologists because it is not viewed as a bad thing anymore for us to recommend that. And I do it a lot, especially with those kids, because they don't know that, even if I tell them, hey, I've cared for Division I athletes that have had ACL tears and Olympians who've had ACL tears, at that moment, that doesn't mean anything to them. They're really thinking about the fact that I'm devastated, I can't do my sport, the thing I love. Their identity, unfortunately, is often tied to that. And so there is a very growing need for that. And when you see a patient that comes in and they're not their usual perky self and they're very despondent about their sport participation or they don't want to participate anymore, when it used to be all they talked about, those are big red flags that there's a lot of mental stress going on. So please don't overlook it.
Yeah. It's everywhere. Healthcare professionals, nurses, doctors. I mean, we have a major focus now on wellness in our staff because everyone is suffering, especially in the pandemic. Social media has definitely played a role in making things worse for everybody. You're constantly bombarded with issues. Cyberbullying is certainly a major problem for pediatric patients, so parents and pediatricians need to watch out for that, and I'm sure this audience is doing that, but it's really a major problem.
Yeah, and it's and obviously as I'm kind of looking at Jennifer, psych issues are such play such a vital and important role in gastroenterology kind of diagnoses of conditions, especially kind of the children with chronic recurrent abdominal pain. It's so often again that psych piece needs to be recognized and needs to be addressed.
Yeah, we in GI, I think we all were feeling this interesting, you have to be careful what you wish for, but as the kids went into shutdown and were at home, those who do have school anxiety that manifests as functional abdominal pain and school avoidance and, really were, having those issues, all of a sudden they were great. They weren't calling us. But the truth is you do that for a year and now you're having new issues, which is, they really are not developing the way they need to, going through those stages, cognitive and emotional stages and developmental stages to be out there in the world. And so actually as school reopened up, they all got terrible again. And so it's definitely been an issue for us in GI because we all got a little bit of a break where the patients were not, they were at home with their own bathrooms and their parents and in their bedrooms, and they were kind of happy-ish for a bit, but that was really a short-lived situation for many of them. So
we see a lot of children with somatic disorders, abdominal pain, chest pain, headaches. We've had kids with psychogenic cough. I'm sure people in the audience have seen kids who have a cough that just doesn't go away. It's the loudest cough you've ever heard. They're thrown out of their class because they're disruptive in school, and they've been on all kinds of medications. They've seen their pediatrician 4 times. They've been to 2 ERs, and we need to really think that maybe this is a manifestation of depression or a conversion disorder, now called somatic symptom disorder. But I think we have to consider there's psychiatric concerns in patients who have symptoms like that. To me, those are the fun diagnoses. When I hear a cough, when I can hear the cough all the way down the hall, I'm pretty sure right away this patient has a psychiatric illness, and we're going to spend a lot of time dealing with that and convincing the family that that's the issue. But I think those are the fun cases to make that kind of diagnosis after the patient's been to many different practitioners.
Yeah, I mean, back to the vomiting for a second, you always want to know, I touch on it very briefly in the talk, but the child who can, eat food and immediately it's coming right back up, so they quote unquote vomit 20 times a day, but they're sitting in front of you looking fine. You say, hey, can you show me? If they can actually do it, that's rumination, and that is very much like the chronic cough, and that, trust me, that gets you out of the classroom very quickly. The entire classroom empties out, and the teacher, is dealing with the ruminator, but cleaning up, etc. But actually, it's really a call. That child does need cognitive behavioral therapy. And then actually to what we're all talking about, unfortunately, there's a dearth of therapists to help them. So on the one hand, you can make the diagnosis, but really, do we have the army of people out there to actually help is a different discussion. So.
Dr. Stricker, question for you is, person who wrote the question says that they're feeling more comfortable with the concept of resistance training for children, but want to make sure you don't send them to a gym that only has free weights and adult-sized machines. What are your recommendations for that scenario?
Yeah, there's still not a lot of gyms that have child-sized machines. There are a few, but that's not kind of the main thing. But fortunately, that's okay. That's not our main goal. Our main goal with kids isn't to get bigger muscles because they often can't until they hit puberty, of course. But we know there's multiple ways that kids can get strong and that are much more appropriate for them. So different resistance bands, different strengths of resistance bands, of course, medicine balls, and a lot of body weight exercises, coupled with kind of what I talked about in the talk, integrative neuromuscular training, where you're using a lot of other things such as balance or proprioception and core strength and all of those things, because our big picture with kids, knowing that they're not as strong as they used to be decades ago, is that we really need to be working on overall physical literacy and improving their strength reserves so that they can actually have muscular fitness and appropriate motor skill development. And so obviously to accomplish those goals, we need much more than just a dumbbell. So many of the times, obviously we don't even send them to a gym. We give them things that can be done that are working on all of these aspects. And if you're lucky to have child specialists that are great in this area, then that's fantastic, but they're not very easy to find. So hopefully this will help.
All right, I think we will end there. Thank you to our faculty, and thanks for all of you for your great questions. As I said, we're going to end the session now, take about a half an hour break, and we'll be back at around 11:30 Central Standard Time for our first seminar for the day. Dr. Lightdale will be speaking to us at that point. Thank you all, and we'll see you soon.